Good morning, good afternoon, or good evening to the CWIS case review series, depending on where you're joining in from. Just to go over some of the rules of engagement. First and foremost, questions are encouraged for both the moderators and presenters. Please feel free to submit any questions to the chat. I'll be monitoring it throughout the talk. And let us know if you have a question, and we'll try and get it answered to the best of our ability. The more conversation that we have, the more everyone learns. So please feel free and empowered to ask as many questions as you want. Just a reminder to make sure that you're on mute during the presentations. You'll know you're on mute if the little microphone on the bottom left-hand side of your screen is red with a line through it. The format, we have 5 to 7 minutes for each of the presentations, and then 5 to 7 minutes for questions after each of the presentations. You can see the link at the bottom of the screen to register for the next case review series in March. And just a reminder that prior to the CWIS case review series are available at the same site. So if you find yourself wanting to go back and take a look at what was said or what was done on any particular case, all of them are available online. With that, I'm going to hand the screen over to Dr. Zach Wariner, who's a practicing trauma surgeon and acute care surgeon at the University of Kentucky Hospital in Lexington, Kentucky. He's in the second year of practice and is an assistant professor at UK. And with that, I'll hand it over to Zach. Take it away.
Thanks. Can you guys hear me?
We can. Yep.
Great. And hopefully you've got the right view.
Perfect.
I want to talk about a case this morning, really an operation specifically for pain, which is not uncommon for what we do in rib plating, but this one was a little bit different than my typical course that we hope for. So presented to us, a 28-year-old female. She's a competitive horse rider. She came from another outside hospital as a referral after chest tube placement for a hemopneumothorax she suffered after being kicked by her horse while practicing in preparation for competition. She's healthy. She's had knee surgery twice in the past, and she takes no medications at baseline. Her thoracic injuries on the CT scan provided from her hospital that referred her demonstrated a series of fractures, 4, 5, 6, and 7. 4, 5, and 6 were each lateral, simple, and displaced. Rib 7 was more complicated, a segmental fracture with complex lateral and a posterior wedge component, both of which were displaced. She was actually booked by one of my partners, and I met her preoperatively, so didn't get to have the typical discussions I usually would have with her, but based on our practice here and the timing and an emergent procedure that went concurrently, I was able to do her operation on his behalf. So we operated on her on post-injury day 1. I performed a right muscle-sparing posterolateral incision. And really the most problematic thing we encountered was severe angulation of the posterior segment of rib 7, where that wedge deformity was. That was quite difficult to get reapproximated. She was fixed 4, 5, 6, and 7 with a bicortical plating system. She also underwent a right VATS hemothorax evacuation, and we left a single thoracostomy tube that you can see displayed here after completion of the procedure. Her post-operative course initially was pretty uneventful. She was discharged on post-op day 5. She remained on the floor throughout her stay. She actually returned to riding on post-op day number 24, much to my dismay, despite my recommendations not to proceed with that at that stage, but felt quite good and could not be kept off the horse. So she did go back to competition 2.5 months after her injury, and felt quite well initially. She came back to my office about 4 months afterward with complaints of ongoing chest tightness. She described constant chest wall pain that was exacerbated by riding. I had a couple of suspicions. One, the way that she holds the reins and the movement of her scapula concerned me because has not a lot of soft tissue mass. But on exam, no movement or manipulation of her scapula really changed anything. I did identify on this chest x-ray a posterior fracture of rib 5 that was not appreciable on her initial imaging. So she did not have this offset fragment that we could see on her initial CT scan. And despite the retrospective knowledge that it's there, I cannot appreciate it on her initial imaging, unfortunately. So that CT scan was done in a different hospital with no recon. So that may have been part of that. But I was a little bit concerned about that as a potential contributor to her pain, just because of the time frame not having described it initially. She also had very easily palpable plates because of her body habitus with a little bit of tenderness to palpation. We decided to give it a little bit of time just to see what progress she made over the next 6 months before making any further decisions. She came back 6 months later, and this recon demonstrates, excellent reconstruction of 4, 5, and 6. Rib 7 is a little bit offensive to my eyes, but because of the complexity of that fracture, I think the alignment is relatively good. But she did have quite a bit of callus formation near those fragments. So we talked about our options, and really she was, at that point, her pain was so substantial that she wanted something to be done. Was not a fan of pain medicine in any way, shape, or form. So we took her back to the operating room after performing a 7th intercostal nerve block. So I did this for a couple of reasons, mostly for diagnosis, to see if she had any component of intercostal neuralgia that was causing her pain, because she really had 2, I think, discrete complaints. One, the constant sharp stabbing pain that I think was related to this, and then the chest pain that she had on palpation. So when we did the nerve block, her chest pain immediately resolved, and that was sustained over the next 3 days while she had the Exparel injection. The chest tightness and tenderness to palpation did not change, however, so made the decision to proceed to the operating room, where we did take her plates out because of the chest wall pain she had on palpation and the excellent healing we had on our repeat CT scan. Also performed a 7th intercostal neurectomy at the time of plate removal. So you can see here the 7th intercostal nerve really disappears into that callus formation along that segmental fracture. So this is where that posterior wedge had been performed. So I was able to identify the nerve posteriorly coming in the bundle, and then anteriorly, you see here it disappears just beyond the suction as we move anteriorly on the screen, or superiorly on the screen. I apologize. So that was divided, and then her plates were subsequently removed. When she woke from anesthesia, she had immediate resolution of the pain that she described, the sharp stabbing pain. She had quite a bit of chest wall pain from the operation that we performed, and her recovery did take a little bit longer, just because I had to extend her thoracotomy incision a little more than previously. But I learned a lot through this case. Operating for pain, as the old adage says, usually leads to more pain for both of you, both the patient and the surgeon. And fortunately, that wasn't the case here. So also appreciated that those offset displaced fractures can cause intercostal nerve entrapment. I've been fortunate up to this point that I've not experienced that. I think in her case that it was likely still had some impingement. And then as that callus formation developed, that's when her pain became more persistent. I think that having achieved a little better approximation of those fragments would have been worthwhile. I did beat myself up a little bit for the muscle sparing approach that I took, just because that posterior segment was so difficult to get together. I think I could have done a little better job in retrospect at that. But also that the intercostal nerve block in her, I think, was diagnostic and therapeutic, although short-lived, because of the pain she had associated with her plates and the chest tightness. We decided that with her occupation, that this would be a worthwhile endeavor to go forward with plate removal for quality of life. And one special thanks to Dr. White. So I bothered him quite a bit about this case. I called him beforehand and said, I don't know anybody that's taken plates out. He told me he could count on one hand the number of times that he's done it in his career, but that he had success each time. Interestingly, I met Tom in the Dominican Republic as a first-year medical student. So this picture is one of my most prized possessions. It's the first time I ever held an instrument in an operating room. And I was so geeked to do anything that it didn't occur to me that when he offered a circ, what a circ meant. And so this is me doing a circumcision as my first operative case, but really was instrumental in kind of shaping my decision to become a surgeon. And I just think that organizations like this, outreach programs like he's already involved in, I think it shows you how small the community can be. And then he's been a resource to me through my career, even beyond helping me to make the decision, but in my patient management and operative interventions going forward. So appreciate his opportunity to be here today too.
Thanks so much, Zach. Great case, great presentation. And I would like to echo what Dr. White said in the chat about appreciate you using the nomenclature for rib fractures. While we wait for some questions to come in, I had two questions. Do you always do VATS as part of your case? And then how did you kind of set up for the neurectomy? Because that may not be a portion of the procedure that some people on the call do all the time.
Yeah, sure. So I typically do. If there's nothing in the chest and they haven't had a chest tube before, or they have complete evacuation, I'll think about avoiding it. But I think that it adds so little to the operation. I think the difficulty and the technicality of it, and I think the benefit of assuring that you have adequate evacuation and good chest tube positioning is worthwhile. So I almost always perform evacuation, and that's maybe a product partially of how I was trained, but I've never regretted doing that and evacuating that clot. I have regretted not doing that before. So that's, at least anecdotally, that's part of my experience. The neurectomy, again, that was something I'd only done once as a resident, and it was for refractory chest wall pain after a thoracotomy. And we did, several intercostal nerves that surrounded the area that we were concerned about. That patient did develop a little bit of, an atonic chest wall thereafter because of that neurectomy that we did in several locations. So, and that was one thing that Dr. White actually cautioned me on, was that, you can end up with developing a chest wall hernia because of the denervation that you provide. So that's why I wanted to get the block done to start, to see if the seventh nerve alone would be adequate to get her symptoms under control. And we were very fortunate that it was. When I took her back, I told her that the muscle sparing approach was not going to be a part of it any longer. So that made it much easier to get that exposed to do the neurectomy appropriately. I still was a little shy on my exposure and had the nerve nicely exposed. And the last move to get that extra little bit of mobilization caused that intercostal artery to become a problem. So she has a single clip that I hope nobody noticed on chest x-ray that is not on her nerve. But that would be my caution, is just that as you expose that area, it will, although I anticipated that potentially happening, getting control of it was not as straightforward as it should have been, just because my exposure was limited. So that would be my other piece of advice, is that just make sure you've got it well exposed and don't torture yourself.
Excellent. And I'd encourage people, if you have questions, feel free to put them in the chat, and we'll bring them to the people who are presenting. That, one thing that I've occasionally found useful when I'm struggling with exposure like that is use either a mini Alexis or a smaller medium Alexis wound protector. And even if you have the muscle exposed and you've cut through the skin, but you don't want to divide the muscle, you can actually just spread through the muscle and put that little Alexis in there. And sometimes it just gives enough to give you that little extra inch or two of exposure and visualization. It's something I've occasionally found useful.
Awesome.
Joe, this is Tom White. Can I take the liberty of the microphone? I'm just such a poor typist that I would take the question.
Sounds good.
If we go back to Zach's CT scan with the plates in situ, there's so much scatter from the metal that sometimes those are really hard to interpret. And I learned yesterday from Dr. Dobin that there's some sort of technique that the radiologist can do to subtract out all that scatter. And I didn't write down the name of it, but is anybody, this question is not just for Zach, but anybody else on the call. Is anybody using or familiar with the way to render CT scans that have metal in them, so you can see that with more clarity?
I don't know the name of it, but I do know that it turns the plates, the way that they reduce the scatter is it ends up turning the plates blue, and the bones are considerably less dense on the reconstruction than normal. I don't know the name. Does anyone else?
I'm not familiar either, unfortunately.
And just another comment from Gerard Baltazar. We've been using the Omni retractor to facilitate exposure, and the ability to retract at various angles helps. All right. Well, not seeing any more questions. Thank you again, Dr. Wariner. I appreciate the presentation. And Dr. Briggs, if you want to bring up your slides.
Thanks for the opportunity. Appreciate
it. While Dr. Briggs is getting set up, he's a trauma and acute care surgeon at Sanford Medical Center in Fargo, North Dakota. And he's going to be presenting on a costochondral consternation, which we're excited to hear about.
All right, can you see that?
We can. That looks great.
Okay. Thanks for the opportunity to present a recent situation I kind of stumbled into. It was kind of outside of my wheelhouse, you might say. So I thought I'd share this with you and get some thoughts on where do I potentially go from here. This is a 37-year-old female who I was asked to see by a friend who's a surgeon in another part of the country. She has been working with this particular patient for better than 10 years now. I was asked to see her because of a broken sternal plate. And the patient, who turns out lives in my neighborhood even, isn't able to travel down to her primary surgeon for a follow-up since this plate broke. She has a pretty complicated history relating to plates in her chest. She had severe pectus excavatum, and in pre-2011 sometime, I can't tell you exactly when, she had an initial repair and subsequent recurrence. Then in 2011, she started seeing this friend of mine who tried to repair this recurrence. Initially, it seemed to work, and then in 2013, while pregnant with twins, she fractured the nuss bars, and in the process, seems like did a lot of damage to her lower chest wall, costochondral junction. Since that time, she's been dealing with that, and in 2014, 2015, 2018, this friend of mine did a number of different procedures to try and repair the costochondral junction on her lower chest wall. Then again in 2020, she had another attempted repair, and you can see as you look at these that there's been bone resections, there's been some cartilage resections. She's had plates placed multiple times. The plates have always fractured. And her last repair was in August of 2020, and again, same types of maneuvers, and again, this particular plate fractured. So she isn't able to go see her surgeon now, and her surgeon's wondering if I can potentially take out this plate from a pain control standpoint and temporizing measure until this patient's able to travel and be seen in a more elective setting down there. So I just recently saw this lady, and I was happy to see that she's overall doing okay. She does have some significant chronic lower chest wall pain. It's kind of always been there, you might say. In particular, with certain upper body activities will cause pain for a couple days or more. But in examining her and talking to her, it doesn't seem like the plate is really the nidus of the pain. The plate is easily palpable on her sternum. We talked through things, and she was of the opinion, and I was in agreement, that unless her pain significantly worsens or she really starts to tie it to the plate, she's not really keen on having surgery for plate removal unless it's part of a more comprehensive attempt to repair the lower costochondral junction. And in full disclosure and honesty, the costochondral junction, the sternum, is outside of my wheelhouse, not an area I've any real serious experience in. So, looking at this situation, it was outside of what I consider myself at all familiar with. It's worth noting that she does remain in regular contact with and in a very good relationship with her primary surgeon. And I think actually she has a telemedicine visit with her today. But she mentioned a couple times through the visit, that she's wondering if maybe another point of view wouldn't be a bad idea, get a fresh look at the situation, before she undergoes another attempted repair. So I wish I had better images and more images to show you, but our radiology systems aren't compatible, so I had to take some off of cell phone pictures, basically. You can see here she's got a plate that runs down her sternum and quite far down onto the costochondral junction. Then here's a lateral too, and this is done in November, which was before the plate fractured. So this is the main picture of the fracture that I had available for the clinic visit. My intention was, if she wanted it removed, to rescan her chest before we did anything, but at this point that's kind of on hold. So my consternation about all this is, while she doesn't want the plate removed now, that could change any day. She could call any day and say, I'd like to have it removed. Technically, it seems feasible, even for someone like me. But am I being naive? Is there anything I need to be aware of from people who have worked in this area more commonly? And then secondly, and I think more importantly, the underlying issues with her costochondral junction remain, and she does want other opinions. And is there anyone out there with this type of experience who I could suggest her to consider seeing? So thank you for your time, and any comments are appreciated.
Thank you very much, Dr. Briggs. Great case, and I really wanted to applaud you for reaching out and bringing this to the CWIS case review forum, because I'm hoping we can get you some good feedback even either now or in the coming days. One question that I received through chat from Gerard Baltazar is, have you considered manual therapies for the rib pain, or osteopathic or manipulative treatment?
I haven't. That's a great thought. No.
One question that I had, it's at least in the sternal fractures that I've plated so far, I almost always will lay two plates down in parallel just to prevent torquing on one isolated plate. What do you know? Was there any discussion at any point about why two plates weren't placed versus that one with the fracture there?
I spent some time going through her op notes really since 2011, and in prior surgeries she'd had multiple plates placed. What I would say is kind of the way I interpreted things. The plates are primarily being used to try and support either cartilage grafts or bone grafts, or cross the costochondral junction from the rib to the sternum, and trying to pull the rib into the sternum and hold it in place. So she had multiple plates placed a couple different times, but they hadn't been like in parallel down the sternum or anything like that, from what I could tell. And this plate, as I look back, just kind of reverse this. Really, what sternal bone she has left, there's really 4 screws from what I can tell in the bone, and the rest is just kind of in the, I'm assuming, cartilage and soft tissue, and I think that it's being used primarily to hold pieces of cartilage graft in place, from what I can tell.
Okay. Does anyone in the chat have any thoughts or comments? Dr. White, I might call you out on this one.
Sure. I'm impressed with these recurrent chest deformity cases, and I'm struggling with one right now, actually. And I just don't know quite yet how to deal with these, and who should be dealing with these. Should these be should we teach ourselves to become basically congenital reconstructionists, or should we be deferring all these patients to people with expertise in that? And I look forward to having more discussions, engaging our Dan Millers and our Mario Gasparis, those who repair pectus for congenital reasons, and bring their expertise into the acute trauma setting and learn more about it. So you put me on the spot. It's not a very eloquent answer, but I just, there's a lot here we don't know. And I'm not sure who or how we should be dealing with these. And we're going to start seeing these more commonly.
Thank you. And Steve, what I'm thinking is we might be able to use the slides that you have, and we could probably send them out to several people on the CWIS listserv group, and see if we can get some additional responses for you. The other option would be to also post it on Slack if you haven't already, and that would be another venue. But I'll send you some emails afterwards to get you connected in and looped in to get see if we can find you a solution, at least the best solution possible to the problem, because it's definitely a challenging one.
Yeah, thanks. Any input's appreciated. All this makes me feel better.
Yeah. And it looks like Sarah Ann said that she's going to connect you with Dr. Miller after the chat.
Thank you.
Excellent. All right. And then just an update. Looks like Dr. White was able to find out that the CT software that erases the scatter is called the OMAR or IMAR, and most CT scans should have the capability to do that. With that, thank you again, Dr. Briggs. And our third presenter will be Dr. Bacon. Dr. Bacon is a visiting instructor in surgical critical care at the University of Utah. And he has quite an interesting case to present. So looking forward to this one.
Hi there, can you hear me?
Yep, we can hear you.
Okay. First, let me apologize. I was unlogged in on my laptop, so I'm on my phone looking at my laptop. So it's going to be a bit difficult for me to point at the screen and particulars of images. So I apologize in advance. I think Sarah Ann's going to help me out by running slides for me. With that said, I would like to present a recent case that Drs. White and Van Borum did, and were gracious enough to allow me to help them with a very complex chest wall reconstruction. Ultimately, what we ended up doing in the second operation was a modified Edwards, what we're calling a modified Edwards quilt repair. Can I have the next slide, please? So our patient was a 60-year-old man, trailer. Back in 2017, he fell out of the cab and ended up landing on his right side on the big diesel gas tank. Fractures, and had multiple previous operations. The initial operation was done in 2010, shortly after his injury, and that was open reduction internal fixation of ribs 5 through 8. Those did fine for somewhere in the realm of months to a year out, where he represented with multiple fractures of his plates. Underwent a redo reconstruction with what sounds like, from the information that we have, repeat ORIF of 5 through 8. And at that point, we believe is when a mesh underlay was placed to fix a traumatic hernia between ribs 8 and 9 in the inner space. He did fine for about a year again, but represented complaining of chronic pain, and had a third operation where what appears to be just some hardware trimming was done to alleviate some of those chronic pain symptoms. He continued to have problems after that, and ultimately ended up reaching out to Drs. White and Van Borum for assistance. I should mention the patient is from Mississippi and traveled quite a ways across country to come out here to Utah to see us. With respect to comorbidities, very large man, has type 2 diabetes that is reasonably controlled on medications only, hypertension. Of note, he does have it's a vague history, but he did have a wedge resection for right lower lobar lung cancer. He did not receive any neoadjuvant or adjuvant therapy for that, but per report from the patient, has had negative imaging surveillance in the interim. But that does play a role in the lack of definition of his pleural space when we were operating on him. And finally, is a former smoker. the image that you're seeing on the side is a representative CT reconstruction showing that ribs 5 through 7 have extant hardware, and actually you can't see it on that image, but rib 8 does have hardware on that as well. Underneath the label for 8, you can see a piece of the mesh that was used to try to buttress and repair that traumatic hernia, and then rib 9 will come into play. Can I have the next slide, please? Okay. This slide again has some more representative CT reconstruction images. Going from left to right, you'll see a posterior view, and then the middle one is a view up underneath looking at the internal surface, and then the one on the right shows the buttressing that was provided from the scapula, and you can see underneath the scapula operation to reconstruct the failure. Rib number 9 was not addressed, and that comes into play because we found that was a non-union that was further exacerbating the ongoing and/or recurrent hernia there, despite the mesh placement. Next slide, please. Again, a few more images. The important thing to note here is the first 2 images from left to right show that piece of mesh that was in the pleural space, and then you can also see that non-union that'll come into play in our first operation, in our first repair. The far right image is just a subtraction image showing the plates that were in place on 5 through 8. Next slide, please. So the first operation was done by Drs. White and Van Borum on the 21st of last month. This occurred 4 years post-injury and approximately 2 years post the reconstruction after the failure of the initial hardware. They performed this through a reopening of his prior transverse thoracotomy. He has multiple scars on his thorax, but he had a very generous thoracotomy there that we went through to perform this operation. What we found there was, again, the prior ORIF of 5 through 8, and then the non-union on rib 9. Specifically, rib 5, we were actually unable to access because of dense scar tissue up under the scapula, so we left that alone. Rib 6 actually was well healed, and so that hardware was removed without incident. Rib 7 had a single lateral non-union where a single unicortical plate was placed to buttress that and repair that non-union. Rib 8 actually had 2 non-unions, one of which wasn't covered by the plate that was in place. So that plate was removed. Again, another long single unicortical plate was placed to repair both of those non-unions. And then the non-union that we saw in the imaging that has never been addressed on rib 9 was repaired with a single plate. Again, all these were unicortical plates. Ribs 7 and 8 were addressed as well with bone grafts that were obtained from the iliac crest to further support those repairs. The intercostal space and the hernia defect there was repaired and addressed 2 zip ties. If we look over at the image, we can see those 2 zip ties with approximation with a normal rib after placement of those zip ties. So after this operation, we were confident that we had a good repair, but we'll see if we can go to the next slide that was not the case. So on post-op day 3, the patient was having some pretty severe post-operative nausea and vomiting, was coughing and retching. And again, this is a big man, and he felt a pop and imaging. I didn't put it up here, I apologize, but it was very clear that the hernia space had opened back up, and we had a failure of our rib space 8 hernia repair. So we took him back to the operating room. reopened the thoracotomy, and we found that both of the zip ties had failed at the fastening mechanism. It had just popped off, and so they were essentially floating in the breeze. So because of this, we felt, and because of the patient's body habitus, we felt that we needed a more substantial repair to give him a durable and lasting repair. So in consultation with Dr. Edwards, Dr. White developed a plan that we were going to go in and do a very extensive and complex repair that ultimately resulted in a 2-layer absorbable mesh repair, one onlay, one underlay in the pleural space that was supported for 2 rib spaces above, 2 rib spaces below, with big suture and then the hernia space itself underneath that was closed down again with big suture and I wish I could point to you, but essentially what you're seeing on the upper cartoon, the gray lines represent what was our absorbable mesh, and that's the onlay and underlay. On the cephalad aspect, we did sutures in a quilting pattern above the rib spaces. And then on the caudal aspects to protect the intercostal bundle, we actually drilled holes and went through the ribs to affect those quilting supports. If I can have the next slide. So here are images of our repair. If we look at the right-hand side, you'll see that we've actually switched orientation from the prior images. So cephalad is actually at the bottom. And what we see here is our initial, on the left-hand most image, this is the first sutures in our onlay mesh. And we can see those sutures are going through drill holes in rib 10, through the rib, and then picking up the underlay mesh that's in the pleural space. I should mention that the mesh that had been previously placed in there actually helped us out quite a bit. We were able to blunt dissect that and remove that mesh without any issue, which I believe was very helpful given the fact that the patient had a wedge resection in that lower lobe, and he was pretty stuck all the way around. The middle photo, what we've done here is we've reflected back the onlay mesh to show ribs 9 and 10, and then the underlay mesh in the space that was developed when that existing mesh had been removed. And then on the right-hand photo, we see the final product, which is our quilting network on ribs 9 and 10. Again, those go through the ribs to protect the bundle. And then on 8 and 9, those are above the ribs. Next slide, please. And post-operatively, our patient did quite well, actually. We extubated him in the operating room. It was quite a long operation to get all of this done. So we elected to put him in the intensive care unit overnight just to watch his pulmonary status, make sure that the nausea and vomiting that he experienced before was well controlled. He went out the following morning to the floor. On post-op day 3, our pleural chest tube was removed. And then on post-op day 11, he was discharged home with the subcutaneous drain in place. He actually could have gone home a bit sooner than that, but there were some social issues that precluded that. He had his initial follow-up on post-op day 18. The drain was still putting out a fair amount, which isn't surprising given that he had a pretty large piece of mesh in there. So we elected to leave that. A week later, he was seen in clinic. The drain output had dropped off, and it was removed. And the patient has traveled home to Mississippi. Dr. White's arranged through CWIS to have a surgeon down there follow up with him and to make sure that he's doing okay post-operatively. Last slide, please. And so just discussion points and to open it up to thoughts and comments. The complex repair that we did, again, was first described a couple of years ago by Dr. Edwards and his team. They initially used a 5-layer repair with a non-absorbable mesh, and it was buttressed with pleated sutures. And they went through the intercostal muscles to affect that quilting pattern. In 2020, that's when Dr. Edwards and his team described essentially what we did, and that was that earlier cartoon image of the mesh repair. That was a 2-layer absorbable mesh with the drilling through the caudal ribs to protect the neurovascular bundle there. And then finally, our repair was what we're calling the modified Edwards quilt, where we, again, used a 2-layer absorbable mesh with the drilling. We did repair the intercostal hernia with very wide, large figure-of-8 sutures, as well as another zip tie to buttress that repair. And then the one thing that we learned through trial and error throughout the case was that a very large angiocatheter works wonderfully to patch that suture through your rib boreholes to cut down on the time of operation. With that, I'd be happy to answer any questions. I'm sure Dr. White has comments. I believe Dr. Van Born's on with this as well. And I thank you very much for your time.
Tony, that was terrific. And I do have one comment. Everywhere he said absorbable mesh, just replaced with non-absorbable. I just need to point that out. This is stratus mesh. This is alloderm-like. It's porcine, and it's incredibly tough. It's like sewing a football, but I don't think you can't affect this repair with an absorbable mesh. It would fall apart. The only other comment I'd make is that these are really challenging. We're all going to start seeing these, and they all have one thing in common, and that's a rupture of their costal margin, and that needs to be addressed. And I think acutely, if you see these, like they cough and they show up the next day, I think repairing the costal defect directly as a part of an overall repair may make some sense. But in this case, there's so much scarring, there's so much distortion and tension on the chest wall that trying to pull the cartilage together with some sort of plate and expecting it to hold is fraught and folly. And you need something that reestablishes a normal interspace distance between the ribs, 8 and 9, or 9 and 10, or 7 and 8, whichever it is. And I think this is one way to do it. And I'm pretty impressed with how solid it felt and how it distributes the tension, the inevitable tension on this gap that is produced by the costal rupture. So we're going to learn a lot more about this moving forward. But Dr. John Edwards is clearly and Dr. Stefan Schulstros in Berlin, those two guys have done more of these than probably the rest of us combined. And we'll look to them for future guidance. But this was our first foray into the Edwards quilt, and I'm pretty impressed with it. And if anybody has a case like this, do your homework before you get in there. Call Dr. Edwards, call me, get a game plan set up because they're challenging. Even with 2 experienced surgeons, we spent 5.5 hours on this operation. So it's not trivial. These aren't trivial. Don, do you have any comments?
No, they are tough. On the original operation with this guy, Tom and I actually had another one that was almost his identical yet opposite twin. And that one we did a little bit differently. We had put in a piece of mesh originally that was not anchored to the rib. It was sutured to soft tissues. That guy's a month out, and I'm still just waiting for our repair to fail. He's still having pain from the zip ties, and I think the difference being that he has a zip tie that's going underneath, probably pushing right on the nerve, and holding thus far a great deal of the tension that this other repair here, the modified Edwards quilting technique, disperses, as Tom says. So, my patient that I saw in the office yesterday really has kind of two of these zip ties that are taking up a lot of the tension. And I think that's what's making it hurt for him. Whereas this patient here has it dispersed, and over time, I think that tension is going to diminish on both patients ultimately as the rib starts to remodel and heal to match the forces. So that's all I'd say. But they are tough, and they're going to be a 5-hour case regardless of how fast you think you are.
Excellent. Well, thanks so much for both of the comments, and Dr. Bacon for your excellent presentation. The graphics were quite helpful in helping the viewers understand what you did. A couple comments from the chat. First, Dr. Erickson just recommended watching Dr. Edwards' lecture on the CWIS channel about costal ruptures. So a shout out there. And then another question from Dr. Briggs, and any thoughts on whether or not better control of his underlying comorbidities may improve his long-term outcome, kind of specifically looking at his weight and metabolic disorders.
Oh, there's one of them in every crowd. Thanks, Steve. Oh, absolutely. But you know how challenging that is. This guy is he's got a BMI of 40 or nearly that, and former smoker, fairly sedentary. If you can figure out how to make these people lean and in better health, let us. I mean, I know it's a worthy goal for sure, but it's how it directly relates to your repair and the success of repair, I think it's challenging to make a one-to-one connection. Obviously, obesity does not help these patients, but the chronicity is really what makes these challenging. When patients have costal margin rupture and ribs that are poorly healed and angulated, they heal in that new configuration, and a simple attempt to just maybe put some new plates on and lash them together with some sutures, it's just not, there's just too much underlying tension, and they within a few days, as this guy did, they revert back to their status quo. So it's really when you just have to look at these a little bit differently. It oftentimes involves if there are several angulated ribs adding to this distortion, you can't repair these with one interspace. You have to modify their chest anatomy and re-angulate or repair the ribs that are several spaces above and below the defect. And I'm getting away from your question. I apologize, Steve, but I just want to reiterate that they're chest wall remodels, and if you try to pull them back together without appreciating how much tension there is on the repair, then you're gonna have failures. Thank you.
Awesome. Well, not seeing any more questions in the chat, and we're about out of time. I wanted to thank everyone again for joining us for this month's case review series, and especially wanted to thank our presenters who took the time to put together the presentations and come together for this hour to really help push the science of chest wall repair forward. So thanks to everyone for joining. Another shout out, please make sure to check out the CWIS Case Review series website, where you can find all of the prior case review presentations, as well as the way to sign up for future case review series. So looking forward to seeing everyone next month.
Thank you, Joe.
Thanks, everybody.